Hello everybody, this is Stephen Zuckerman in Baton Rouge, Louisiana, and I am going to give a presentation regarding the effects of COVID on the nervous system. Now, this information is obtained from a review article written by a Dr. Nath, who is head of virology at the NIH, and published in the most recent Continuum, which is Neurology journal, which this last one was about infectious diseases. Now, coronaviruses have been around and have actually caused some neurological problems, but not to the extent that the SARS-CoV-2 has caused problems, because this severe acute respiratory syndrome coronavirus has had so many mutations that it is much more adept at replicating and adapting to humans. At first, it seemed to me that neurologists were going out of their way looking for neurological problems so as to not be left behind by their pulmonary colleagues, and it looked like they were trying to make it seem like this pandemic also caused a great deal of neurological problems, when it didn't really seem like it did. But as it turns out, it does cause a lot of neurological problems, and I had to eat some humble pie. So let's dive into how the coronavirus and the nervous system interact. Now, I hate talks which are just lists of various things, but fortunately for me, I'm giving it and I don't have to listen to it. But many of the acute effects of the virus result as its affinity to attach to angiotensin converting enzyme 2 receptors that are very prominent in the respiratory tract. And so in regards to the nervous system, we can categorize complications either by where they're located in the nervous system, central, peripheral, etc., or by when they show up in regards to the infection. And that's in fact what we're going to do in this talk. We're going to separate parainfectious syndromes, which occur during the acute infection and involve those listed here, from those which occur after the acute infection is resolved, but the immune system is still activated and can attack and cause various neurological problems. So in regards to the parainfectious neurological complications, these occur during the acute viremia. And one of the most common ones is that of anosmia. So loss of sense of smell, also causing loss of sense of taste, and it's estimated about 40 to 60% of people may have this complication. It's thought that it may have indicated a less severe involvement of the virus, but that's been disproven since it's difficult to test smell and taste in people that are intubated. Most of these people get better, but some people have some residual decrease in their sense of smell and therefore taste. And this complication, anosmia, is due to the support cells of the nasal mucosa being very rich in ACE2 receptors, and macrophages are activated, and there is swelling with resultant impairment of the olfactory bulb, though the neural tissue in and of itself is not affected, not attacked, not invaded by the virus. So that's a relatively minor neurological complication compared to that of strokes. Now, this is estimated to occur in 1 to 5% of hospitalized patients, and whenever one discusses thrombosis, you have to invoke the name of Dr. Virchow for some reason. I think he gets a percentage of every stroke. But it's his triad, which involves vascular endothelial injury, hypercoagulability, and decreased mobility, which is obvious in people that are acutely, severely ill with COVID. And this cartoon depicts that the blood vessels may get the COVID viral particles attacking their ACE2 by the spike protein, either by a hematogenous spread, perhaps via retrograde axonal transport, or even by a nerve, and here is depicted the vagal nerve, and post-mortem studies have shown that there are viral particles seen in the GI tract, which may then contribute to these. And when it gets to the endothelial cells and the ACE2 receptor is seen on the endothelium, causing a great deal of immune response, endotheliitis, breakdown of the blood-brain barrier, with potential of proteins and or blood to flow into the brain itself, causing pathology. So we've seen strokes in otherwise young, healthy people. They may present with multiple areas of arterial occlusions. There's also the possibility of a central venous thrombosis, and pseudotumor cerebri has been described as a complication of COVID, microhemorrhages. Now, everybody who has COVID and presents with a stroke should be placed on anticoagulants, despite the fact that there are microhemorrhages present, though certainly the risk-benefit ratio favors that of anticoagulation because of potential for multiple arterial inclusions. And in regards to the pathophysiology, it is useful to look for D-dimer to see if there's some DIC or coagulopathy. Antiphospholipid antibodies have been described as well. And patients may have a myocarditis causing cardiac emboli, but it's probably this small vessel endotheliitis or endothelitis, however you pronounce that word, which is the major cause. Now, if one has other known risk factors, certainly they're at higher risk for developing these strokes. Now, in terms of immune-mediated, since we know that the virus itself is not neurotropic, and so various conditions have been described. It was thought that leukoencephalopathy could occur, but it's suspected that this is actually the injury related to an anoxic or hypoxic ischemic damage, and not in fact immune-mediated, as opposed to this other condition, acute necrotizing hemorrhagic encephalitis, in which there are bilaterally symmetrical thalamic lesions associated with hemorrhage. This is a susceptibility weighted image B. And so, as we talked about before, protein and blood cells can leak past the weakened blood-brain barrier. Now, this is known to be mediated by cytokine release, and therefore is amenable possibly to immunotherapy. Now, high-dose steroids have been tried unsuccessfully, but there are certainly reports of plasma exchange or IVIG which have successfully treated this manifestation of a COVID infection. However, far and away, before I get to the far and away, I'll get to the close and here. There's this other nervous system involvement, which is also related to cytokine release, which can cause any of these wide spectrum of neurological disorders. It doesn't even have a name yet. It's sort of like the old-timey neurology where it was, if you named it, you were of some good, but there was no way to treat it. This is so new, it doesn't even have a name, doesn't even have an eponym. But fortunately, we do know it's cytokine mediated and has responded to either corticosteroids or IVIG in some patients. Now we get to the most common manifestation in hospitalized patients, in particular the ICU, where they have altered mental status. And this could be anywhere from a delirium to a coma to seizures, and it's got a very wide differential diagnosis. It could be a metabolic encephalopathy. It could be related to the hypoxia. It could be ICU psychosis, related also to medications. So it's got a wide range of possibilities. It does tend to occur more in the elderly, and the development of a delirium will certainly prolong a hospital stay and produce a worse prognosis overall, in that 2/3 of patients who develop this, when they're discharged, are not independent of activities of daily living. So in this case, it's sort of difficult, or a judgment call, to determine whether their alteration in mental status is appropriate to the metabolic encephalopathy with all of the above possible considerations. But it would be useful to obtain investigations to rule out the other possibilities. So an MRI scan looking for strokes or those other conditions, spinal fluid looking for meningoencephalitis, and again, it's not related to direct viral invasion of the meninges or the brain, but is more likely immune syndrome, and perhaps obtaining oligoclonal bands from the spinal fluid or an IgG synthesis rate would be helpful in determining whether there is in fact activation of an immune-mediated process. And in that vein, or actually in that subarachnoid space, cell cytometry looking for T cells and B cells, if possible, or even obtaining a cytokine panel may be useful in defining which part of the immune system needs to be either suppressed or augmented in order to help resolve that neurological syndrome. So that takes us out of the parainfectious time frame and into the post-viral. In other words, there's no more virus around, but the immune system is now kicked in and has involved any of the nervous system. Most commonly, there is a peripheral nervous system involvement, and several reports from various institutions have shown that Guillain-Barré syndrome, either the typical demyelinating form or an axonal form, or even a Miller-Fisher variant, which everybody remembers is that which involves ophthalmoplegia, ataxia, and areflexia, have been described, as well as other cranial neuropathies, radiculopathies, plexopathies. Any part of the peripheral nervous system may get involved in an immune process, as well as the next part, the neuromuscular system, and so myositis or polymyositis, or even probably in those at risk to develop it, myasthenia gravis has been described. Now there is a certainly immune-mediated ADM, acute demyelinating encephalomyelopathy, which has been described as a post-viral syndrome previously, But this can occur typically radiographically. One sees ringing enhancing lesions in the brain or the spinal cord, and they present with altered mental status perhaps, or focal neurological exams. They recently had a coronavirus infection, and the MRI scan shows characteristic findings. Oops. And so this is T-cell mediated and does respond to immunotherapy. And finally, transverse myelitis, which one doesn't see in multiple sclerosis, since those are usually restricted segments. These transverse myelitis people have at least 3 spinal cord levels involved, sort of like Devic syndrome or neuromyelitis optica, and again is treated with immunomodulation. So those are the post-viral involvements. And then there's the so-called long-haul symptoms. And the exact incidence has been estimated at between 10 and 30%, but nobody really knows, because these people are not necessarily hospitalized. They may not have even known that they had COVID. And so we don't really know the exact percentage of people, but if it's anywhere in this range, given the number of people worldwide who have been infected with COVID, it could be a very large number. The development of the long haul syndromes, which are listed here, and are 3, they include cognitive, autonomic nervous system, or chronic fatigue syndrome type symptoms, is independent of the severity of the COVID. So you may have had a mild case, you may have a severe case. It doesn't make you more or less susceptible to the development of the long haul symptoms. And demographically, these are tending to be younger people, and there's supposedly a 4-to-1 female to male ratio of the involvement that develops these long haul symptoms. Some do resolve, but others don't. And so let's talk about some of these syndromes. And a lot of the symptoms may, like chronic fatigue syndrome, be nonspecific, and so therefore need to rule out various medical problems such as hypothyroidism, etc. They don't really know why this occurs, but it may indicate that there was incomplete resolution of the viral load, and so the persistence of virus is what causes the immune response, which then leads to these syndromes. We don't really know whether immunotherapy is of any benefit, since there have been no trials to date. So let's talk about the 3 different types of long haul involvements. We can have cognitive involvement. So there may be memory problems, distortion of time, mood disorders, sleep disorders, or in the elderly, which again is less of these long haul people, but in the elderly, if they have some underlying dementia, there may be an acceleration of their Alzheimer's disease, for example, with further neurofibrillary tangles and amyloid plaque deposition, causing their dementia to get worse rather rapidly. The second sort of long haul involvement is with the autonomic nervous system, and these people can develop palpitations, a tachycardia, or postural orthostatic tachycardia syndrome, POTS. They can develop orthostatic hypotension. It's possible that those arterioles are further constricted more than normal and therefore cause hypertension. GI involvement may involve gastroparesis, constipation, and loose stools, and I hate reading lists. And then finally, there is the so-called myalgic encephalomyelitis, which is misspelled here, not on purpose, and is characterized by exercise intolerance. Again, unknown what causes it, unknown how to treat it, but it's certainly been well described. And for those of you who've listened to all of this, I don't know how you did it. Congratulations. And hopefully it'll be somewhat helpful in managing further COVID patients with neurological complications. Thank you very much for listening. Bye-bye.